Greeting, friends. Welcome to Heartforward Conversations from the Heart. This week, I am so delighted to focus upon a topic that has intrigued me ever since attending my first conference in Trieste back in 2017. At that time, there was a significant emphasis on the importance of designing community-based services with human rights as a strong guiding principle. There were speakers from the World Health Organization stressing the significance of the Convention on the Rights of Persons with Disabilities. I remember thinking, we don't discuss human rights much in the context of supporting or providing services for people with disabilities in the U.S. We instead defer to protecting civil or constitutional rights. I honestly did not know the difference. The World Health Organization has made it a priority to promote, through its Quality Rights Initiative, training and sensitivity in order to improve the quality of care provided by mental health service providers. This is a global initiative to change mindsets and practices in a sustainable way and to empower all stakeholders to promote rights and recovery. With the help of my friends in Trieste, I was introduced to a wonderful psychiatrist from Pune, India, Dr. Soumitra Pathare. He enthusiastically accepted my invitation to enter into this conversation. He is passionate about human rights, and he has been involved with the World Health Organization on these endeavors for many years. As you listen to this conversation, imagine that you are putting on a new set of glasses that have a filter to open you up to new concepts, new ways of seeing people, a new frame of reference. I learned so much just talking with him, and I hope you agree that this opens up new language that might inform policy change in the U.S. So it's morning in Los Angeles and evening in India. Good evening, Soumitra Pathare. It's so good to see you.
Good evening, Kerry. Good evening. Well, good morning, Kerry. Yeah. That's what
I've had my coffee. I hope you have a glass of wine nearby or something too.
Well, I just had my dinner, and it's like a 12.5 or 13-hour time difference, isn't it? You're waking up, and I'm getting ready for bed after a while.
Exactly. And when I checked setting up this interview, I saw that there's that 30 minutes, that extra 30 minutes. So we all have to Google why India is 12 and a half hours ahead. But so grateful to have you here today. And I have been looking for quite some time to try to find somebody that I could talk to about the issue of human rights. And Dr. Mazzina, who you know, Roberto Mazzina from Trieste, was actually here in this podcast studio a few months ago. He had come here to Los Angeles, and I said, I'll take you to the airport if I could whisk you into the studio for an hour and just talk about your trip. He was here with the LA Sheriff's Department. So I said, I need to talk to someone about human rights and how it really intersects with the world of mental health policy. And he said, I have the exact good person for you. So here you are.
Thank you. Well, it's a small world because, Mazzina is from Trieste, and Trieste is really well known because of Franco Basaglia. And Franco Basaglia is one of my heroes, like a model, someone you aspire for. So it's really a small world.
It's wonderful how we're all connected around the same passions we have to treat people with dignity and humanity. So, Soumitra, tell me a little bit about you. I know that right now you are director for the Center for Mental Health Law and Policy for the Indian Law Society, but I'm always curious about how someone entered the profession of psychiatry, and what was it about your upbringing, your early years that brought you into that field, and were you actually a practicing psychiatrist, or I know you're in the policy world now, so tell us a little bit about your background.
Okay, well, there's nothing exciting about it. I had a very Indian middle class upbringing in the city of Mumbai, which most people know on the western coast of India. I ended up in medical school, probably not so much by choice as much as the aspirational Indian middle class thing to do. Since you're good at studies, you just are expected in the generation when I grew up, you were expected to be a doctor or an engineer. And those were the only two things you could possibly do. Any self-respecting middle-class family would expect them their son to do that. I ended up in medical school in that way without actually knowing why I was there. Um, I plowed my way through medical school, had a good time. I mean, no complaints or no regrets at all. But by the time I finished med school, I was actually sure I didn't want to do surgery. I found it all very gory. Medicine was extremely boring. And obs and gynae was not my cup of tea. I didn't like kids either. And so ultimately, I was left with a couple of things to do. One was pathology, and I thought that's wonderful because I don't have to deal with people. I could just sit somewhere in the lab and look under a microscope, and that'll be great. So pathology was one, and then the other one was psychiatry. And psychiatry was unusual because, if somebody had said to me when I was 18 or 20 that you'll end up being a psychiatrist, I would have laughed my head off and said, "Are you crazy? I mean, I'm not going to become a psychiatrist. Why would I become a psychiatrist?" And what happened was I went and did my psychiatry terms. When you're graduating and doing your med school, you spend 3 weeks in the psychiatry department. And I didn't, I didn't remember psychiatry as the patients I saw, the people I saw there, but I did remember this professor who was extremely charismatic, very, very charismatic. And he was very impressive. He was very well read. He had a sense of humor. He was super intelligent. And literally, I mean, when it came to it, between pathology and psychiatry, the only reason for taking it up was because of him. Like, oh, he's a great guy. I'd love to work with him. And that's how I ended up in psychiatry. And again, when I did my undergrad psychiatry, it was a place where everything was biological psychiatry. And so I was, I kind of had this thought that I was going to discover the problem in the brain for why people get mental illnesses. And so biological psychiatry was it. And then after I graduated as a psychiatrist, I went off to the UK and then met another charismatic psychiatrist who very interestingly happens to be a Jamaican who's settled in UK. And, he was doing this deinstitutionalization work in London, and said, would you like to work in this, what was conventionally described as an old bin, and with really difficult people. And that's how I ended up in a mental hospital, working there with the last bunch of the most difficult to place. Tooting Bec was a big hospital with 3,000 patients. It was one of the biggest in the UK when it was...
and what year would that have been?
About 94, 95. And Tooting Bec was the largest mental hospital at one time, 3,000, 4,000 patients. It actually was its own closed community. The staff lived on campus and everything. By the time I went to 94, deinstitutionalization had gone far ahead. And so the entire site, which was many, many hundred acres in size on the edges of London, was shut down and had these ghost buildings and had the last 100 or 150 people who were really difficult to place, And I worked there for 6 months, and I actually loved it. I quite liked it. I quite enjoyed my interaction with those people. And then there was an opportunity to actually place these really difficult people in small homes in a street in South London. And we did a small bit of, not small, a reasonably big bit of research where we looked at what would make it possible for reintegration of these people into those communities. And we were very successful with it. We wrote a lot of papers about it at that time. And that's when I got hooked into community and social psychiatry. And, from 91, when I left India wanting to be a biological psychiatrist, by the time it's 99, 98, 99, I thought psychiatry is nothing but social. There is no, what's biology got to do with psychiatry? So in a span of 8 years, it completely changed over. And then really not much after that. And in 99, if you had said, oh, you're going to become a human rights and law person in psychiatry, I would have again said, oh, no, I know nothing about it. I have no clue what that is about. And in 99, I took a pretty momentous decision, and my professor in Tom Craig, who's the guy I worked with at Tooting Bec, Tom Craig was very upset with it, which is that I decided I was going to come back to India and just quit NHS and everything and said, I'm going back to India. And I remember Tom Craig saying to me once that, okay, bring me a map and show me where is this city you're going to, because I said, I'm going to Pune. And he said, where is Pune? And I said, like, show me on the map. And so I showed him and he said, have you got a job? I said, no. Is there a job? I don't think so. I don't know. What are you going to do there? I'll go there and find out. And he was like, you're utterly, completely mad. What are you up to? And you do know you can always come back if things happen. But I was very sure, I've never done this in my life. I just go forward. I burn my bridges on the back and say there's no returning. It's if you remember that, I don't know if you've seen the movie called The Man Who Would Be King. You must have.
Yes, of course.
Like in that, the guy just cuts off the bridge and says, listen, you got no option now, fight or you're dead anyway. And so that's how I've always lived my life, kind of double or quit. And so I came back to India and with nothing, I tried working in a public hospital in India, which didn't work out at all. Not because I didn't want to work, but because they wouldn't offer me a contract. They said, we'll give you 28-day contracts. And I said, 28-day contract? I can't function like this. I'm 35 now. I've got a kid by then. I can't function like this. And so I decided to quit without knowing what I would do. Ended up with what I think was clinical depression, although nobody actually picked it up except maybe my wife. And even felt a bit suicidal at that time, thinking, look, I don't want to live. This is like, everything I've done. I'm 36 and I built my career and it's all back to zero. And going back to the UK was like, it would have killed my self-esteem. I couldn't do that. I just said, I'm going to continue what I'm doing. This is it. So I almost spent a year doing absolutely nothing. My wife was a gynecologist and she would go off to work in the morning and I would stay home with the kid and I would do interesting things like I would paint chairs or paint things in the garden or like say, listen, I planted 4 trees today. And, my wife would say, okay, did you manage to write any of the stuff you want to write? And no, I don't want to write, don't want to do anything. And then around 2002, the WHO got in touch and said they were coming up with this service guidance package for all the countries. So they were going to come up with this big bundle of 4 or 5 manuals for countries to guide them how to organize their services. And they asked me, would you write the one on community-based services? Would you write a package that we were doing for that? And well, I was absolutely doing nothing at that point in time. So I said, fine, I'll do it. And I did that. And then they said, oh, will you do one more? And they asked me to do, they said, oh, will you do one on human rights and law? And I said, human rights and law, I know nothing about this. Like, what is this? And they said, no, you've done a pretty good job with community services. You'll be able to do this. And so they kind of asked me to do it. So I taught myself in 6 months to bring myself up to date on what is going on and wrote that human rights and law chapter manual for them, the small one, the service guidance package had that. And then around 2005, they said, oh, we want to do this big manual on mental health, human rights and law. And I have no idea. I still to this date, I have no idea why Michelle Funk was the person in charge. I have no idea why Michelle asked me to do it. I'm probably the most inappropriate person. I don't have a law background. I'm not a lawyer. There are many people who worked in law and human rights for donkey's years. And she said, will you do it? And I spent the next 2 or 3 years of my life literally just doing that because it had multiple revisions. It would go out to thousands of people who would send in hundreds of comments and then you try and answer all of them and you make a new version. So I did all of that. And then by the end of 2007, I thought, I actually know a lot about this stuff now, from where. So you can see I moved from biology to social psychiatry to human rights and law over a period of like 15, 16 years.
It strikes me that you are the perfect person to have this conversation with. I'm so excited, but I have to ask this question. So you made this migration from so-called biological psychiatry to community and social psychology that you saw psychiatry that you saw evident in the UK with community-based services and moving people out of the institution into the community. You come home, they're obviously not interested in this idea in India. Like, was there any place in India at that time that was beginning to embrace kind of community-based services? Or were you really like a fish out of water?
Some of it. Well, there was some of it. NIMHANS, which is a national institute based in Bangalore, had been for a while doing this kind of experimental work around community services. But nobody was talking about deinstitutionalization, and community services really ended up being basically displaced OPDs in the community. So they were still following a very medical model. You see what I mean? It was community in the sense, well, instead of you coming to the hospital, I'll come to a clinic near your house. But it was still the medical model of diagnosis, and here is the treatment, and here are the medicines. And that was it in many ways. But not really community services in the way that that one would want to talk about. You know, there was no question about deinstitutionalization and all of that at that point in time. It was not something that was happening. And one of the things that I did want to do when I had first come back was to actually set up a good community-based service, and to even look at deinstitutionalization. And I just realized that I was too disruptive. In 2001, I was talking stuff which was like way out for people. It was too disruptive. They didn't know what this was all about. And, somebody said to me, not in 2001, but one of the psychiatrists said to me in about 2013, he said, you belong to the lunatic fringe of the profession. And I thought that was hilarious. I said, that I belong to this lunatic fringe.
So it strikes me that had you not had that experience in the UK, you actually have to viscerally experience how it is you would work with people in community and come alongside them as humans. And if you can't really read about it, you can't take a class in it, you almost have to do it to believe it. Yeah. And I think that, I'm eternally grateful to Tom Craig for that chance. Tom, I don't know why Tom asked me to do it. I remember telling him, look, I know nothing about this stuff. Why do you think I can get 100 of the most difficult people? Nobody's able to get them resettled. And you think I'll be able to do it? This is crazy. And he said, no, you'll do it. You'll be fine. We also set up a community-based service, and it was one of the first assertive community services, assertive outreach services in UK. It was one of the first ones to be set up, and I was leading that team for a year. And we had I jokingly used to call the nurses and say, listen, you're like the Marines, okay? You're going to be out there first, and you get all the trouble. You handle the trouble, and it's great. You get a chance to handle trouble. You should look forward to it. And, by the end of the year, we had nurses queuing up to join our team saying, hey, this is a great place to work, I've heard. And so we went from where nobody wanted to be on our team. And, they gave us nurses who had been in this hospital, who had been institutionalized for 50 years. And we took them and we kind of actually got them working so wonderfully well that we soon had younger nurses straight out of college coming in and saying, we want to join your team. It's just fantastic stuff and just fascinating. That is
working.
I'm going to include some information about that in the episode notes, that institution and what you were involved with, because I had never really heard that story. So let's talk about human rights. The reason I really wanted to have this discussion is because I think in the United States, we rarely talk about human rights. We cloak everything in the concepts of constitutional rights or civil rights, and especially in this situation we are facing today in America, where we've got people living on the streets, and you will have civil libertarians who will say that people have the right to sit on that bus bench for 10 years, right? And I've been thinking that maybe by just understanding better what human rights are, it might give us a different framework to kind of look at how it is that we should come alongside serving people. So can you unpack for a moment the difference between civil rights and human rights? Just since you had to learn it yourself many years ago when you wrote that first World Health Organization policy manual.
Well, I mean, human rights are, to me, human rights are very simple. Human rights are rights that we all have, you and I have, merely for the fact of being human. That's it. There's nothing more to it than that. That we all enjoy those rights. We are born with those rights. Nobody gives us those rights. Your civil rights might be given by your constitution. Human rights are not given. You're born with them and you will die with them. And that's what they are. So in that sense, the word human rights actually is far more broader and encompasses all of human endeavor in that sense. And they apply to all of us, and your human rights are no different to mine. And somebody with mental illness, their human rights are the same as mine. There's really nothing less or more about people with mental illness to have those human rights. If I wish to be treated in a certain way, then people with mental illness should also be treated in the same way. I mean, it's at its bottom, it's basically as simple as that. Now, I know it's all, people will say, oh, come on, it's more complicated. And I think we make it complicated. I think it's actually quite simple to say everyone has a right to live a life of dignity, including people with mental illness. And that's not very difficult to do. Paradoxically, I think, there are two paradoxes of the American mental health system, looking at it from across 12 and a half hours and exactly the other side of the world away. The first paradox is that America is a champion of human rights across the world. But America is not a champion of human rights for people with mental illness in America. I mean, I don't see how you square that circle. America will go to war across the world to protect human rights. I mean, that's something America has always done. But America will not go to war to protect the human rights of Americans with mental illness who are in their own country. The paradox baffles me. And the second paradox is every time you talk about deinstitutionalization across the world, people, especially mental health professionals, will give the example of America. They will say, oh, look what happens in America. If you deinstitutionalize, you just get people thrown out on the streets. And America has more people with mental illness in prisons than in hospitals. And this I've heard it so often. It's just amazing. You go in any country, anywhere in the world, that's what they'll quote as the American experience. And it might be true, but that's not deinstitutionalization. That is just throwing people on the streets. I mean, that's simple English. There's no jargon with that. You put people on the streets, provide them with no support, and say, oh, get on with your life, and say you got your rights. That's rubbish. There's no rights. That's not the way you treat people. And there are many successful ways of doing community integration and protecting people's rights from across the world. And in many ways, Europe has really been a much better example. But everyone talks about the American example, whereas, the best examples have come from the UK, from Italy. Very few people in English-speaking world actually know much about the Italian experience, except a few, we know about law that was passed and that kind of stuff. But, unfortunately, that's how it happens. So those are two American paradoxes I've never understood.
Yeah, I'm so glad you said it and I didn't. And I remember, excuse me, when I attended my first conference in Trieste in 2017, there was a whole huge panel about human rights. And Michelle Funk was there from the World Health Organization. And there were a bunch of us, and we were all looking at each other like, why are they spending so much time on human rights, right? And we started Googling human rights, because you are absolutely right. We think about, people will go overseas to deal with sex trafficking or, child slavery or what have you, because it's a human rights abuse. And then when we started pointing the finger back at ourselves, we realized, oh my goodness, there's a bunch of these human rights. So talk about the United Nations Declaration of Human Rights. How did that come about and why? why at that point in history, and what's encompassed in the UN Declaration of Human Rights?
Well, look, the UN Declaration of Human Rights is really, if you wanted to know human rights, then that's it. Every single UN convention after that has only elaborated on the UDHR. So it's not like any new rights have been created along the way in the last 50 years. What has happened over time is that the UN, the United Nations, have actually elaborated those rights and made it specific for specific groups. But the UDHR is real, and that's the other interesting thing. Okay, the UDHR was championed by an American. Eleanor Roosevelt championed the UDHR. You wouldn't have had the UDHR without her. And it came out of the horrors of the Second World War that the world had experienced at that time. And that everyone said, well, never again. And here are things where does that mean we didn't have human rights before 1948? Of course not. We had. What 1948 and UDHR did was codified them, okay, and said, look, we've got it now written down. So you can actually point to a piece of paper and say, hey, listen, that's a right I have, okay, and because it says so here. Because that's how societies and communities tend to work. So it actually codified that stuff. And, when I do teach, I teach on many of these courses across the world, mental health courses, where you get asked to do the human rights one. And it's always interesting. You look at Article 1 of the UDHR, and it says all people are born with equal rights and dignity. I get people to read it up, and then they say, can you read it out for me on the slide? And then they say, all people. And I say, no, I think you're reading it wrong. And then you ask someone else, and they say, no. I say, Louis, you guys are missing it. Like, aren't you reading it? Like, what I can see there is all people except people with mental illness are born with rights and dignity. And then they laugh about it and but I think it gets through to them that, look, all really does mean all. But we've been doing an exception for people with mental health problems, that we said, oh, well, all does not actually include people with mental illness, as if they are not human. You see, that's the subtext then. Then what you're saying is they are not human, or they are lesser, they're children of a lesser God. They are less human. They have less rights. And it's okay because, they are lesser human beings. Because that's what you're saying. And if you're not, then you should be saying if all those rights that apply in the UDHR should also apply to people with mental health problems.
So you mentioned how after the initial declaration, 1948-ish, over the next several decades, there have been, I think you described, elaborations where there would be an additional focus on a particular subcategory. So the elaboration that we are most interested in is the Convention of Rights for Persons with Disabilities. And it looks like that was adopted in 2006. So that was right around the time that you were doing this work.
Yes.
What took so long to enter into this elaboration, and what might have been controversial about that, and what is inside it's referred to as the CRPD?
Okay, lots of questions. Yeah, let's unpack one by one. Look, it's been a process, okay? What happened was, after the UDHR, you had the International Convention on Covenant on Civil and Political Rights and the International Covenant on Economic, Social and Cultural Rights, which really are the two covenants. And if you read the UDHR and those two covenants together, which is called as a Bill of Rights, it really covers everything. And the only reason you had these two separate ones was, this was 1950s, Cold War, where the Americans and their allies would be happy to sign up to the civil and political rights, and the Soviet Union and their allies were happy to sign up to the social, economic and cultural rights, but not to the civil and political rights. So they said, okay, we'll create these two separate ones and you can sign up to whichever one you want. But the fact is that rights are indivisible. You can't have one without the other. And like, if you don't have civil rights, if you're not allowed to vote, let's say, how do you protect your right to property, which is an economic right? You can't protect one right without actually being able to enjoy the other right. So there was this kind of a fiction of two separate groups of rights that people created. And that's how things went on in the 60s and 70s. And around the 70s, people started saying, listen, but while we say this applies to all people, people are getting forgotten. And so they started off with children, and they said, well, look, children are getting forgotten. What about children's rights? And so you had the Convention on the Rights of the Child, which came up around the 70s. And then someone said, after a while, people say, hey, what about women? I mean, women are not getting their rights. And so you had the CEDAW, which is the Convention on the Elimination of Discrimination, all forms of discrimination against women. And so you got the CEDAW and you said, look, these are vulnerable groups. And then someone said, what about racial discrimination? Race is a big issue. And so you had a convention on elimination of all forms of racial discrimination. And that's when somebody said that, listen, what about people with disabilities? They are forgotten. Their rights are not being addressed. What are we doing about that? And that's how you kind of ended up in a situation where you actually had a convention on the rights of persons with disabilities. And now, going ahead, people are saying, like, what about older people? What about their rights, which are not getting protected? And so you got the UN currently working on trying to think of a convention for older people. So what these specific conventions do is that they elaborate on those rights for that particular group in their context. Okay, so what does it mean for the right to informed consent if you're a child, for example? How does that work? What does a right to property mean when you're talking about a woman in that case? So, it's about elaborating it for those particular vulnerable groups. And that's what the CRPD does. It says, look, these are all the rights, the UDHR. Now, how do these rights become real for this particular vulnerable group, which may have its own handicaps and impairments around it? And the CRPD, this is such a fascinating thing. I don't think the US has yet ratified the CRPD, at least when I last saw it. They hadn't ratified the CRPD.
No, I saw that 182 countries in the world have, but the United States has not.
Yeah. So, but what is very funny is, not funny, but ironic again, is that, the CRPD is driven by a social model of understanding disability. Okay. And that was something that was elaborated in the US to begin with. That's how it started off from the US, the social model of disability. And that's what influenced how the CRPD works. And if I can explain to you what a social model of disability means, because I think it's very important to understand that while you're talking about the CRPD and mental illness. So, in a medical model, which is what we've all understood, the medical model of disability is that, let's say if I'm blind, okay, what would you say my disability is? You'd say my disability is that I cannot, there's something wrong with my eyes. I'm blind, so that's what my disability is. I can't see, but it's something physically wrong with my eyes. And that's the medical model. The medical model places the disability, locates the disability in the individual. So if I'm on a wheelchair and I can't walk, then they would say, well, something needs to be done about your legs and back because you can't walk. So there's something wrong with you. And so the medical model really, in that sense, pathologizes disability, right? Now, if you use the social model of disability, you know what the social model of disability would say? Hang on. If you cannot see, you are not disabled because you cannot see. You are disabled because you've created an environment in which you're not able to do everything that everyone else is able to do. So, for example, so you're not being able to see is only an impairment. That's not the disability. The disability is because you haven't got everything in Braille, or you don't have the screen readers. You've not created an environment in which people could actually participate fully in life. After all, what is disability about? It stops you from participating fully in life. And so if you allowed people to, let's say wheelchairs, okay, somebody who can't walk, if the wheelchair could go everywhere where somebody walking on their feet could go, there would be no disability because they would not be excluded from anything. They would be able to participate fully with everybody else. Okay, so it also moves the notion away from a charity model You don't have to be nice to people. You just have to ensure that you create an environment in which they can be included so that they can participate fully in life like everybody else. So this is not about being nice to people, doing charity to people. This is about saying, let's create a level playing field. And the level playing field is everyone needs to be able to get into this house, whether it's steps, ramps, lifts, whatever it is, whatever it takes, but everyone needs to get in there. And you can't be saying to people, well, I'm really sorry if you can't walk, there are only steps out here. That's exclusion. Okay. And so the social model focuses on the environment. Okay. Now, that's great when you say this is wonderful for physical disabilities, works very well. But in the case of mental illness, it's not the environment. Providing a wheelchair access or providing a ramp is not going to make the person with mental illness feel more included. In the case of mental illness, it's the barriers are not environmental barriers. The barriers are attitudinal barriers. Okay. And the attitudinal barriers are that people with mental illness are not responsible. They are violent. They can't look after themselves. They don't know what's good for them. These are stereotypes, prejudices, discrimination. All of that happens, which are the barriers for full inclusion of people with mental illness. And those are the barriers that we need to actually dismantle. If we want people to be included, and everyone should be included, then those barriers need to be dismantled. It's easy for our societies to understand the need for a ramp or the need for braille. It's easy for them. And it doesn't cost them anything to say that's fine, because it's not like they are doing something. But it's harder for them to actually see how there are stereotypes about people with mental illness actually cause exclusion. And then it's about them as a society. Whoa, I'm the one who's actually excluding this person. And that's harder to change, and that's more difficult to accept. And so, there is a lot of this kind of exclusion that happens without even thinking. And sometimes they're trying to be helpful. Don't get me wrong. I don't think everyone's just being nasty to people with mental illness. Sometimes they're trying to be helpful. But, it's like they think this is a safety net. The problem with the safety net is that after a while, you get caught up in the safety net and you can't actually walk around because you're now got wrapped into a safety net, which doesn't allow you to do anything. And they say, well, you're safe in the safety net. Oh, yeah, but I'm safe, but I can't live. I can't breathe in the safety net. And that is really a problem. And so people say, but I'm trying to be helpful. I'm trying to save you from yourself, kind of a thing. But people don't need to be saved from themselves. People do need to be allowed to experiment. Fundamentally, the issue that we've not addressed with people with mental illness in our societies, and not just in America, is that are two specific words. One is making mistakes. And secondly, taking risks. It's in the nature of human beings to take risks. None of us live a risk-free life. When you decide to speak to me this morning, you are taking some risk of some kind, and I'm taking some risk in talking to you. I might make a fool of myself. You might edit this badly and make me look like an idiot. Anything. I'm taking a risk. Everything I do takes a risk. Everything you do takes a certain risk. And the other thing is we all make mistakes. And that's the only way we learn. Now, if you're going to tell people with mental illness, okay, then look, you shouldn't take any risks at all. Okay, like no risk, zero risk. Well, that's not life, that's not human existence.
I have a perfect example for you. Boy, you're making this so clear to me right now, the difference between environmental and attitudinal barriers. So one of the things we do in the United States, this is that safety net you're talking about. We will say you will qualify for Social Security disability income. You will get a check every month for this amount of money. If you work, though, you will jeopardize that income. Because if you make too much money in a job, you will run the risk of losing your benefits. And I have talked to so many people who say, I really would like to get a job, but I'm really afraid that I might lose my benefits. And then it takes a long time to get back on the benefits, and they get completely stuck in the safety net and not even able to take the risk to maybe try to get a job.
Yep, exactly. I mean, that happens all the time. And, we don't allow people to make mistakes. That's the other thing. It's so funny. Kerry, you and I, okay, we handle our own money. Yeah. And many of us blow it up on all sorts of wrong things, harebrained schemes, ridiculous ideas. We're going to double our money overnight, put our money there. We all do that all the time. We've all made those mistakes, including me. And nobody said after that to us, listen, you shouldn't be handling your money. We will handle it for you. Okay. Because, you could just blow it off. You could become broke. You could become bankrupt. And we can't let you become bankrupt. And so we'll take over your money. Now, would that make sense to any of us? It wouldn't, isn't it? So why should you do the same for people with mental illness? I mean, how does it change the minute you say, oh, but you've got a mental illness, so it's okay to do that. So we will have someone look after your funds. Your choices don't matter. But you know what? I want to give away $100,000 of my money to XYZ. No, you can't. You have a mental illness. We think that's not a good idea. But it's okay if you did it, because that's completely fine. So, and again, there it's a safety net logic. Oh, you know what? Somebody will abuse you. Somebody will take advantage of you. Well, great. That's imagine telling a woman you shouldn't be going out on the streets at night because, somebody might rape you. We don't say that, do we? What we say is that, well, you better stop the rapers, not the people, not women walking out. The same thing, if somebody you think is going to take advantage of people with mental illness and steal their money, then you please take care of the people and stop them from stealing their money, but not tell me that, look, you can't have a hold of your money because you know what, somebody might steal it off you.
So with that, those are such great examples. Would you argue that trying to employ a human rights approach to reimagining how it is that we come alongside and be in community with people living with mental illness, we've got to have a community-based system that helps to provide the supports and the socialization and the protection so that they can exercise those rights?
I think we shouldn't even start saying that there should be a community-based system. And I know you'll say, what do you mean? Let me try and elaborate. If you have diabetes, okay, even you have diabetes, it's a chronic illness and it can kill you. And many people, almost half of the people with diabetes are non-compliant with their medicines. They don't take their medicines very well. They get hypoglycemic attacks, or they get into all sorts of trouble. They become unconscious. They go into coma. They end up in hospitals. They ruin their families. Okay, they do this all the time. But nobody talks about institutionalizing people with diabetics, and they don't say, oh, we have community care for diabetes. No, does anyone talk like that? That we have community care for diabetes? No, that's the only care. Just the only care you can do is community care. What you do when you have diabetes is you say, listen, you need to be able to work, you need to be able to live with your family, you need to be able to look after your kids. And our job is to help you manage your diabetes in such a way that you're able to do all of these things or most of these things, even if they are with certain limitations. Now, replace the word diabetes with mental illness. And that's your paradigm, which we should be using. And not having this institution versus community kind of, this binary of an institution versus community. There is no binary. What I'm saying is there is only one thing, which is to help people be able to live a fulfilling life in their own communities with their own families, friends, neighbors, colleagues. And the job of mental health services is to be able to support those people to be able to do that. And just like with diabetes, people with diabetes occasionally end up in a hospital because they get into coma or something. People with mental health problems might occasionally end up in hospital. And sometimes they will repeatedly end up in hospital because they don't take their medicines, just like people with diabetes do. They go and don't take their medicines repeatedly. Ask so many doctors who treat diabetes. They'll say, oh, people will keep on, not learn. They'll go home, stop their medicines. They'll do funny things. They'll come back and get relapse and they come back in. But nobody says, oh, let's institutionalize these people.
So it's almost as if we have to lead with the rights and then build the support to allow that to flourish, to happen, as opposed to trying to just tack them on to a system that doesn't acknowledge those rights.
Exactly. Rather than trying to fit people and their rights into a system which is not designed for it, what we need to be saying is that people and their rights exist, and the system needs to be built around them. To be able to enjoy those rights. And then the system needs to work around them. So the system needs to act as an envelope or a wrapper around people's lives, rather than to say people have to wrap themselves around the system and try and get it to work for them.
So, it's hard to imagine how we could even begin this in the United States, because we have built-in protections, no risk. We have fallen into the abyss in this space, as far as I'm concerned. I wouldn't even know where to begin. I'm wondering if I know you had experience in India, in Gujarat, where you were working to introduce what the United Nations calls quality rights, which I think is their program to try to raise the application of the CRPD in communities. Are there lessons from what you did in India that we could maybe translate into an American context?
I think there are lessons, not just what we did in India, but everywhere that quality rights has happened. I think one of the most important thing that quality rights does is that it changes the mindset of those providing the services. I think there's a need to shift your mindset. There's a need to shift from seeing the world in a certain framework and seeing people with mental illness through a certain binary, to starting to see them as humans first. I think what happens is the minute you get a label of having a mental illness, it sticks with you for the rest of your life. And people look at you very differently the minute you say you have a mental illness. It's so funny and bizarre, but that's how it happens. And that's what leads to people not then taking treatment, because you will lose rights the minute you get the label. So I think one of the things that quality right really does is actually challenges people's preconceived notions and people's worldviews around people with mental illness. And that is something that is required. And if that can be challenged and done in a place like India, then I don't see why something like that cannot, in a very low resource setting, and where the absence of resources is actually a real barrier to any kind of change. If it can be done in India, then I don't see why places like America, which are far better resourced in terms of human resources, you're still better resourced even financially than we ever will be. So I don't think it's about resources. It's about mindsets. It's very funny, but nobody ever assumes that they would become mentally ill at some stage themselves, that they would get mental illness. Now, my question has always been, and when I say this to doctors or mental health professionals, I say, but look, if you developed a mental illness, would you want to be treated like this? Like, is this how you would want, like you lose all your rights? And they would say, well, but I won't develop a mental illness. Why would I develop a mental illness? I wouldn't. And I would be very sensible about it. And but it gets them to start thinking that, listen, yes, you could develop a mental health problem. Anyone can. Nobody can predict. And if that happened, then you don't want to be losing your rights. I mean, one of the reasons why I would want to fight for the rights of people with mental health problems is exactly that if, God forbid, if I developed a mental illness, I'm going to ensure my rights are protected. I'm not fighting for them. I'm fighting for myself.
So when you talk about changing the mindset, changing the worldview, changing almost a cultural context, I trolled you on the internet and I found some of your YouTubes and podcasts and whatnot. And I can't remember what community you were referencing, but you talked about a case study where, in working with the staff at this particular agency or institution, whatever, as you were training and reframing their views, they didn't even realize that they had actually been abusing human rights. Could you offer some practical examples of what that epiphany might feel like for people?
Um, I think it is. I think it requires giving people the space to be able to do that. And you know the one of the things when we were working with nurses with the Quality Rights Project, and this I've seen across the world. So this is not a Gujarat specific problem. This happens everywhere. Minute you say, "Oh, you got a human rights program," the mental health professionals and staff get extremely kind of wary because they think, oh, now everyone's going to come and point fingers at us and blame us for abusing people's rights, and that's what they're going to tell us how horrible people we are. And so there is a lot of that kind of wariness that mental health services have about the notion of human rights, and that's again a very we had to actually tell people, look, this is not about you. This is not about you and your abuse. This is about people with mental health problems and their rights. So this is not to say we are not here to point fingers and tell you you're doing a bad job. What we are here is to try and tell you how you could help people with mental health problems actually exercise their rights. And so you kind of get away from this notion of finger pointing and blame. Mental health professionals do a pretty good job given the resource constraints that they have to work with. Okay. I'll give you an example. And this is where I think our politicians and our society has failed everybody. Imagine you're a nurse in a low and middle income country. You're a nurse on a mental health ward at night. And you're likely to have like 50 people, and you're the only nurse around, and some of whom might be disturbed. And then what does she do? She says, look, I need to ensure I'm safe, and I need to ensure they are safe. Yeah, I mean, pretty sensible stuff. And so how do I ensure that they are safe? Well, maybe I'll just tie up the people who are very difficult or violent or I'll inject them and put them off to sleep. That's even better. I'll give them something and they'll sleep off till the morning, because then they won't harm anybody. Okay. And how do I protect myself? Well, maybe I should just ensure I sit inside my cabin and lock the door. I don't blame that nurse. I don't blame that nurse at all. He or she is actually doing, given those circumstances, the most sensible thing. What we should be blaming and should be pointing out fingers to is a society which puts that nurse in that situation of having to deal with 50 people at night with no help and maybe not very well trained, poor quality accommodation in which they have to do all of this. And unfortunately, we don't look at that at all. We just say, oh, well, look at that nurse. She tied up everyone, or she just sedated everybody. And she wasn't doing that. And most nurses don't set out, or almost all nurses I know don't set out to say, let's abuse people. They're not joined nursing to abuse people. They've joined nursing because they want to help people. But if you put people in a very difficult situation where they can't actually can't ensure that others are protected and they are protected, they do what they think is probably most protective. Like in our context, for example, I hear these stories. I sometimes hear these stories in families. There's a elderly mother alone, nobody else, and a 30-year-old person with long-standing chronic schizophrenia, mental health problem. Okay, and he's known to wander off. He will wander off and get lost, and maybe he's got lost a few times in the past. And she has to go to work, because if she doesn't go out to work, there's no way the two of them can get fed. So what does she do? She locks him in the house every day and goes. Now, is she being abusive? I don't think she intended to be abusive. She didn't set out to be abusive. And that's not abuse. That is abuse by society. We should be asking our societies, why do you put that woman in a situation where the only way she can go out and earn a living to be able to feed her and her disabled son is by locking him up all day?
So that is such a great, good example of moving away from, like you say, blaming the nurse, blaming the grandmother. It's not about the person. It is about the context in which we have place people with the lack of support and vision for how it could be done differently. So one of the things, when Dr. Mazzina and the group came from Trieste several years ago to tour our system in Los Angeles, and we took them to Skid Row, and we took them to the county hospital, and we took them to the jail. What they saw, I was looking at these things through their lens now. I had their Italian hat on. In the county hospital, there's locked doors. There was the room with the bed with the 4-point restraints ready to be deployed. In the jail for people who are, considered dangerous, that they're chained to furniture, and I remember our Italian friends saying, wow, under the UN Declaration of Human Rights, this is considered torture. I'd never thought about the word torture before. It just wasn't a word that came up in an American context. So I've been fascinating because I've been going through the quality rights training myself online just to.
Well, America never also ratified the Convention Against Torture.
Okay.
There is a Convention Against Torture, and America has never ratified that one either.
Okay, there you go. And I understand we have not ratified the one on children either. So, but one of the modules, the training modules I know is on how to move away from restraint and coercion. And so because it's so prevalent in the United States, how is it that you create a context where you don't have to restrain people?
You can't, there is, by the time you reached a point, and this is what nurses and doctors will say, they say, here's a guy who's being violent and going to beat someone. What do you want me to do? Not restrain him. That's the wrong point to intervene. I mean, that's not the point at which we should be discussing, don't restrain the guy. I mean, I would be silly to say at that point. What we need to ask ourselves is that what has been the trajectory and the pathway by which that person arrived at that level, where it was now inevitable that you had to restrain them, right? And unfortunately, we don't do all of that. Along the pathway, there are many points where one can intervene without reaching a point where somebody will need to be restrained. So for example, and it starts from not getting into hospital to begin with. Like if we had enough support for people in the community so that they didn't get into hospitals or they didn't need to get into hospitals, then that's already at one level you might have prevented any restraints happening. If they did get into hospitals, you could have tried to do it in a way where you had better services. The interesting thing is in every country, if you ask the mental health staff in the hospital where they work, okay, and say, would you want to get admitted in this ward if you had a mental health problem? And they'll say, no. Well, so you see, this is the thing. You have created services which nobody actually likes. You don't like being admitted here if you had a mental health problem. You work on this ward, but you expect other people to like coming into this ward. I mean, why should they like coming into a terrible place which you don't like going into? So you then say, well, you won't come in. You're not complying, or we'll have to forcibly put you in. Well, maybe you wouldn't have to put people forcibly in if those places were better, were more inviting, and actually help people so that people would come voluntarily, right? And if that happened, you wouldn't have restraints, for example.
It's so good. Another aspect of the CRPD that I found mind-blowing, actually, is the notion that we have a human right to wake up in the morning to a sense of purpose to our day. So I woke up this morning happy that I was going to see you on the Zoom. You are part of my purpose today. I had purpose in preparing, for this. And we have deprived people of the opportunity to pursue purpose, at least in the United States.
Well, everywhere, not just United States.
Lack of, there's no need to go back to school or to try to get your high school diploma. And, you don't want to get a job because you might lose your benefits. And even in some of our residential facilities, lawsuits have prevented people from even being able to peel potatoes and help in the kitchen because somebody abused that, back in 1968. And that, so now nobody can help cook a meal because, they're not supposed to. Just talk for a moment about that human right to a sense of purpose and vocation and how powerful that is.
I mean, does that need explaining? I thought it's very self-obvious, isn't it, that you need to have a purpose in life. And even sometimes your purpose in life might be to just laze all day. And that's still a purpose. You know, you choose to say, I'm going to laze today and do nothing. I'm just going to lie around, maybe have a book in hand or not even have a book in hand, do nothing. And I'm just going to drink cups of tea or coffee and do nothing much. And that's fine. But then the next day you might choose and say, look, I'm going to go out and do something else. So I think that's really, really important for people to be able to make decisions. The problem with people with mental health problems is that, or with severe mental illnesses, for example, is that you don't even let them make simple decisions. Like, I'll give you simple decisions, and it happens all the time. Like, what should you wear today? I mean, why should somebody else decide for you what you should wear today? I mean, that's such a basic decision. Oh, you can't leave it to them. They'll just dress very badly. Go out on the street. There are tons of people dressed terribly without mental health problems. And if that is the criteria, dressing badly is proof of mental illness, then half of this world, probably or more, is got mental illness. I mean, people dress badly all the time. They buy rubbish clothes. They buy stuff. You think, why? You spend money buying that? Oh, God, oh my God. Somebody should take your wallet away from you. But you won't let people with mental illness choose their clothes. So like if they were, as simple as that. You don't let them choose their clothes. Or, if they decided, well, I want to have a burger. That's not healthy for you. Sorry. It's terrible for you. I mean, look at the number of people eating burgers every day. Look at obesity. Look at what's going on in the rest of the world. And then you say to this poor guy, no, you can never have burgers because you should live healthy. And it's those tiny little things. It's each of those small little things. Eleanor Roosevelt said very well. She said, what is human rights? Human rights, where do human rights begin? And she said they begin in small places nearer home. And that's so true. That's where human rights begin. Human rights is not about that big stuff out there. It's those tiny things. It's about being able to wear the clothes you want. It's about being able to eat the burgers you want. It's about being able to go out and do nothing, as you said, for a day if you want, or go out and have a round in the park. And it's all of those things that we need to be talking about. Human rights are in those small places, in those small things, not in the big stuff. The big stuff, we all take care of it. Yeah, but if we don't take care of it,
the importance of choice and agency in one's life. We could talk all day, and I actually think I would like to bring you back next season because I know this is going to stimulate more conversation. And I just have to tell you, this is not a conversation we have in the U.S. We really don't. So I feel like you're helping, me put a big toe into the water to start to, create some ripples. I want to ask you one question. Like in the United States, is there anybody, I know you go to conferences, you're involved with the World Health Organization, and you're connected in this community. Are there any kind of good thinkers in the United States on this topic right now that we might want to watch?
Okay, I mean, I have a couple of friends, really. Maybe at some stage you want to bring him on, Professor Stein from Harvard Law School, who writes a lot about disability. He doesn't have a mental health problem, but he writes a lot about disability and has lived experience of disability. And you might want to actually bring him because he's far more eloquent than I am when he talks about the CRPD. And he's also a law professor. So clearly that makes a huge difference. And I suspect because he lives in America, he probably might be able to contextualize a lot of the CRPD for you in America much better than someone like I could do. I know that Gary Belkin, for example, has been doing some really fantastic work in New York. Gary is a psychiatrist, and you might want to at some stage maybe speak to Gary for the work that they've been doing in New York in terms of providing community-based social care. But those are the two people that come to mind straight away. But I was, I wanted to make a point in which you might edit it out if you like. But it's very interesting. You talked about people are not allowed to help in the kitchen because somebody either hurt themselves or hurt someone else. And this is the sanitized understanding of risk and dangerousness about people with mental health problems, which makes no sense to me, at least for America. So for example, every time there's been this whole gun debate in America, which I read about, then they'll immediately jump to mental illness. Okay. People with mental illness, you should be doing mental health checks on people with mental illness. Well, let's face it. For every 100 deaths that you have with guns in America, 54 are suicides. Okay, and only 46 are homicides.
Wow.
So if you are really concerned about gun deaths in America, then it is suicides in America that you should be concerned with guns. If you stopped guns in America, you could reduce suicides by 5,000-10,000 every year. Now, nobody talks about that. It's very funny. The whole discussion on gun control or on gun rights and all, nobody talks about suicides. Whereas 54 out of 100 deaths due to guns is suicides.
That's the first time I've heard that statistic. So you're absolutely right. Yep.
Well, I didn't produce it. It's the Pew Center. They looked at the deaths for 2020, I think, and said, look, 54% suicides, 46% homicides and other causes. So this is the American Pew Center producing it, not, I'm not coming out with it. But so what I'm saying is that what I'm trying to get at is that we have a very bizarre attitude towards risk and dangerousness.
Yeah.
We don't actually define, because if we took a logical approach to dangerousness, then you should be worried about the suicides, not worried about somebody stabbing someone with a knife. I mean, that's really not what happens. What really happens is people kill themselves more frequently with the knife or with the gun than stab somebody else. So I think this whole dangerousness discussion is all driven by stereotypes, which unfortunately I think even the media has played a role in creating.
I have to ask you one more thing, but I am going to bring you back, Soumitra. I've been taking notes during this whole conversation. I've learned so much from you, and I know my listeners are going to so appreciate this conversation. But the last thing I want to ask you, which is off the beaten track here, and when I was reading about you on some article, you said that you like traveling, and we do hope you will come back to LA again because it's been 30 years, and you like meeting new people. And then it said you dream of being a cheesemaker someday.
Yes.
so you just have to tell me what's that all about?
I have absolutely no idea, but I just love. I would love to I would love to stop doing mental health and become a cheesemaker, become an artisanal cheesemaker. I know how to make feta, okay? I can make good feta. Ask my friends. They say, when are you making the next lot? I just don't have the time to do it. But yeah, buffalo milk feta. That's what I love. Not goat milk feta, buffalo milk feta. It's a rarity.
Somehow I don't really think about cheese and Indian food, right? Or am I missing something?
No. There is Indian cheese, which is called paneer, which is probably the. But then I got up. I just got taken in by cheese when I lived in the UK. And then the Italian cheeses. If there's something that I remember Italy for, and I've visited so often, is even on holidays. And my wife and I once on a holiday in Venice. I think it was our anniversary, and we sat near a canal at one of these restaurants, which had a table outside right next to the canal. And a great guy who, I think we got there about 11, and we were there till about 7 in the evening, just having carafes of wine and cheese. And And this is the kind of life I would love to be able to live every day. I suppose my wife says you'll get bored after 5 days. It's all very well. It's all very well for a holiday. You can't do it every day. Who knows? I mean, I wish I could do it every day.
She may be right. Well, again, thank you so much. You've been so generous with your time. It's been so much fun. I could tell you and we would have a lot of fun having a glass of wine and have some cheese and crackers together. I hope we have a chance to meet someday in person. And
looking forward to that, Carrie.
Thank you.
Take
and
care.
Now you can head off to bed soon, and I'm going to start my day.
Thank you. You have a good day
All right.
a good weekend ahead.
Thank you. Bye-bye. Thank you for coming on this journey with me to begin to look at human rights as a framework for how we might approach treatment, care, and support for people living with mental illness in our communities. We heard reference to the importance of choice, living a purposeful life, the importance of peer support, the freedom to take risks and make mistakes, everything we seem to preclude in institutional or risk-averse settings in the U.S. We also learned that the United States has yet to ratify this treaty, the Convention on the Rights of Persons with Disabilities, despite the fact that 165 other countries have. I will keep looking for people to help us better understand this issue and find out who are some of the leaders and change agents in this space in the American context. Meanwhile, I am working to nail down the final 10th episode of this podcast season, so it will be a summer surprise. I thank you for listening and supporting this podcast, and I am so appreciative of my team at Verdugo Sound here in Glassell Park, who provide all the technical support I need to bring you a quality listening experience. See you next time.